Well, Meg, thank you very much for having me today at the Clinic for Facial Orthotropics. How are you doing?
Doing very well, thank you very much for coming down.
Thank you. Should we begin with the questions?
Yeah.
All right. Can you begin with a brief history of the orthotropics profession?
Well, Orthotropics was set up by my father. I think he wanted to differentiate orthotropics from what we did and his views and his treatment from conventional orthodontics. Conventional orthodontics was about straightening teeth, and the word orthodontics means ortho, straight or correct, and dontics, teeth, to mean straightening teeth. Whereas my father wanted to come up with a new term so that not only did it mean a different thing, but so that you could differentiate yourself in orthodontics from conventional orthotropics from conventional orthodontists. So orthotropics means correct growth rather than correct or straight teeth. So it's correct or straight growth, and it differentiates us significantly from orthodontists. And that was the concept of it. You'd need to ask him exactly when he came up with the term and started this process, but it was about 30 years ago. He's been doing this treatment in the region of 40 to 50 years. I mean, he treated me. And it gently evolved from him being really an establishment character. You know, he was, I wouldn't say the blue-eyed boy of orthodontics at the time, but he was definitely very much within the establishment of orthodontics. And I think somewhat naively, he thought that as he came out with these ideas and concepts, the orthodontic profession would say, oh, but of course, John, I can see you're exactly right, and would go with him with their determination to find out the truth and knowledge. And that naivety, I think, was misplaced, because as soon as you start to be different, the medical establishment has a tendency to distance itself from you, and he became progressively more distanced until he became probably the opposite of the blue-eyed boy, the most opposite of most infamous orthodontist. And I think he stands now as probably the most infamous orthodontist in existence, with his ideas generally derided as being wrong. I mean, the very word Dr Mew is almost a synonym of bad science and being incorrect. And when I ask people why, frequently they actually don't know. And when I ask people what's wrong with the orthotropic concept, where it's not evidence-based, it would appear that most orthodontists I'm talking to actually think it's some form of functional appliance incorrectly, and they can't actually say what's wrong with it. They have got no clue with what the concept is. They just think it's wrong because someone else has told them it's wrong. And it's a byword of bad science and poor conceptualization.
It seems to me that there has been some science done that shows that does provide evidence for orthotropics.
There has been, yes. It's certainly not gold standard RCT style research. It's some quite nice research, particularly the twin research. I don't think you could ever repeat that ethically in a modern environment or modern society. Back when my father did that twin research, of course, you didn't have such ethical concerns. And he's done the Best Faces paper, as well as numerous other small bits of research on orthotropics itself. But clinically, it's not proof. You can't really prove anything. And against most research done in modern medicine, modern orthodontics, which is relatively poor, I think it holds its own. It's too easy within orthodontics to say you don't have evidence, because there's almost no evidence for anything. So, yes, we have some evidence. We certainly want more evidence, though.
When we have evidence that it doesn't meet the standard, you're saying, of the industry.
Well, yes. I think the evidence we have doesn't meet the industry standard. However, I don't think there's any evidence, or almost any evidence, that meets their own industry standard. So we have to be a little bit realistic. You can't experiment on growing children.
Right.
And because you can't experiment on growing children, there's very little known. And people don't really want to put the time and effort in for longitudinal studies, seeing something for a long period of time. People want, a quick fix.
Right.
They want to publish something, they want to get it out there, and they don't want to be following up people years in advance. It's difficult, time-consuming, and it's not giving you that answer now.
Do you think a lot of this short-sightedness is economically motivated?
I think
Seems that taking out teeth is quick and easy for the practitioner, though not best for the patient.
I often say that who makes money? A dietitian or a liposurgeon? Because one of them drives a Ferrari and the other one tends to cycle. And who's really doing the beneficial work? I would argue it is most likely to be a dietitian.
Because they're preventing the issue.
They're preventing the issue. Because prevention doesn't make money. The number of hours that it takes us to treat a patient is disproportionate from the amount it takes to make someone's teeth straight. And we need to treat a patient over a long period of time, because by definition, growth happens slowly.
Right.
And I would say that to do a conventional orthodontic case takes something in the region of 3 to 4 hours of chairside time. To treat a patient with the orthotropic method takes somewhere in the region of anywhere from 20 to 40 hours. And the costs don't add up. It's never going to. And it's far harder as well. We have to change an individual. Whereas if you put brackets and braces, you are going to change an individual. So you are going to effectively do their homework for them, which is, I think, why treatment isn't stable. Because if you do the work for someone, they've not changed. If they've not changed, you've not treated the cause of the problem, well, I get you wearing retainers forever.
Because we need to train the muscles and fix the habits, right?
In medicine, we need to treat causes. We're not treating symptoms. And the evidence suggests that malocclusion, aka crooked teeth, is a symptom of the way your face has grown, and of craniofacial dystrophy, which is the term that I've developed to try and explain the greater overview of what's happening. Rather than just focusing on teeth, I'm really trying to focus on the way the whole face changes. So I've termed this craniofacial dystrophy to describe how faces aren't growing perfectly, and because faces aren't growing perfectly, that's leading to crooked teeth. So crooked teeth is a symptom. And straightening crooked teeth is like, well, putting makeup on a melanoma. That's not going to cure the problem. What's going to cure the problem is actually treating the causes. That's what medicine's about. And that's the only way you're going to actually cure it. Yeah. And I think there is a big financial implication there.
Right. What percentage of orthodontists do you think are enlightened to these ideas?
Yes. I would. Well, it depends whether we consider these orthodontists functional orthodontists or mainstream, fixed orthodontists. You have this slight difference between the fixed orthodontists and the functional orthodontists. And it goes back a little bit in history, where in America you had Edward Angle, who came up with this concept of placing bits stuck to the individual teeth. and making the teeth straight. Whereas in Europe you had places like Robin and then Andresen, and more recently, of course, Clark with the twin blocks, who come up with functional appliances. And functional appliances aim to modify the way a child bites together. So when they bring their jaws together, the appliance guides them into a different position, with the concept that you can make growth modification. Now, we're greatly confused with functional appliances, or we couldn't really be more different from functional appliances, but people look at our appliances and say, oh, well, they look like a functional appliance, so think that we're doing functional appliances. And the concepts that we talk about vaguely fit the theory of functional appliances. Now, taking that standpoint, I would say that the vast majority of orthodontists, particularly in the US, but around the world, tend to be focused on fixed appliances. So the sort of 60-odd% are doing everything with fixed appliances. And many of them don't believe functional appliances work, which in many instances is true. Then you have the function.
Sorry, why is that? Is that because of lack of compliance on the part of the patient?
I think going on a slight tangent to explain functional appliances can be worn in one of two ways. Someone can either wear a functional appliance like this, and then the functional appliance works brilliantly. The child's only using that functional appliance to guide where they grow. Another group of appliances, for patients, will wear their functional appliances like this. And, well, because it's uncomfortable for them to wear the appliance. They've gone from this, you place the functional appliance in, and they go to this. And at those, you'll have the most awful result.
Because that increases vertical growth.
Correctly. You're lowering the tongue, you're opening the mandible more, so the whole face has a tendency to fall even further. Now, when you place a functional appliance, you'll get this range of different results. And I think it often depends on the first few cases that you treat as an individual. If you treat a case that goes fantastically well, you'll be switched on, and you'll think functional appliances are fantastic. And you'll sort of blindly ignore the ones that don't go well. Whereas if the first few appliances you do go badly, then you'll focus on every bad case you see, and you will think functional appliances are terrible. And there's always this bias that the only patients you see that saw your orthodontist up the road, your colleague up the road, are his disaster cases. So if you judge the guy up the road from the cases you see referred to you, you'll assume he's the most incompetent orthodontist in the world. Now, if you took in functional appliance groups and you considered only the good cases, you would think functional appliances are fantastic. If you only considered the bad appliances, you'll think functional appliances are terrible. But if functional appliances aim to move growth of the mandible forwards, whereas what they tend to do is this. So they pull back on the maxilla as much as they pull forward on the mandible, because all they do is generate a force between the top jaw and the bottom jaw. And they only really work when you close your mouth together, hence the term function, which of course is fleeting, doesn't last for long, it's a moment in time. And I think they lengthen face. Well, the evidence clearly shows that they lengthen the face, like all forms of orthodontics, but sometimes quite notably. And of course, we don't really agree with functional appliances. Now, to go back to the question I asked you before, you'd asked me whether many orthodontists around the world are really enlightened to these ideas. Well, many of them, so a good approximately 40% of the orthodontists, I'm guessing, use and believe in functional appliances. Many don't use many, and some use a lot. But out of that remaining 40%, they're more enlightened because they believe growth can be modified. So they believe it's not all written down in the genetic code. So they will attempt what's called growth modification. However, nearly all of them will finish with fixed appliances. And I think fixed appliances have become such an industry norm. And to get perfect alignment of the teeth, or as I often say, lining up the deck chairs of the Titanic perfectly, is a complete goal of orthodontics. It is. If you look at, there was a gentleman, an orthodontist called Andrews, who came up with the concept of Andrews' 6 keys, and it's now a byword of a good orthodontic result. I have orthodontists who criticise me for leaving the tooth slightly rotated. So most of orthodontists, almost all of orthodontists, will finish with fixed appliances, and I think that would probably count for 99.9, probably 9% of orthodontists. Now, of course, the way in orthotropics we look at this is that you have to make your own teeth straight. If someone does your homework for you, they will always have to do your homework. Whereas you have to do your homework yourself to learn and change. And it's only then that you'll actually maintain your own teeth straight. So if you get your teeth straight, you'll hold them straight forever. You might not get them quite as straight as if we use fixed appliances. Or there's a range, Thomas, you saw earlier, did perfectly. But some don't as good. However, whatever you achieve is far more likely to be maintained. And if we've changed the real causes, we've changed you, at the end of the treatment, your teeth continue to get straighter, which is, of course, the ultimate goal, really. And the whole process of orthotropics is it's a teaching process.
Great. So in your practice, what consequences have you seen from extraction and retraction?
I've seen some horrendous cases. I can't put it any other way. I have. Frequently, you don't actually know quite what happened because you don't see the before and after photos. But some people have bought some good before and after photos, but often just by chance they happen to get. Usually it's a good lateral profile, so it's a good side profile. And I've seen, some faces ruined. Some of them with help and with change and improvement. But I've worked in a conventional orthodontic practice a bit. Okay, he was more enlightened, so he was taking out less teeth. He was definitely trying to modify growth. But nevertheless, you saw consistently faces dropping a little bit, and sometimes faces dropping a lot.
And I am familiar with a measure called the indicator line. Can you explain that to me?
The concept of craniofacial dystrophy that I described is that the faces of modern humans are lengthening due to a change primarily in the muscle function and the tongue position. So we're dropping our mouths with weak muscles and the face is lengthening. Well, if the face lengthens so it drops down and back, it would be good to have some measurement that's in that orientation. And we take the premise that the initial movement of the top jaw dropping back is not reflected in the nose position, because the nasal cartilage transcends all the way through to the back of the to the base of the skull, back of the facial complex. So initially, as the face drops down and back, the nose isn't affected. And because of that, you can make a measurement from a line taken through the tragus of the ear, through the very tip of the nose, where that bisects a line from the tip of the teeth, running up across the first point of contact of the nose, where these 2 points meet. The length of that is the indicator line. And that is only an indication. And I sometimes worry that it's taken too seriously or too much is read into this, because the clue's in the name, it's an indication. But as an indication, it's amazing what it can tell you. It's amazing how it can uncover cases where there's a deeper problem going on. And particularly when I compare the upper to the lower, it can sometimes give me some good guidance on that. But again, it's only an indication, and all people will be slightly different. But it's a good place to start. And it's a good place to start. It's a good concept to make you think.
And again, the reason this works is because, as you said, the nose is a fixed point. The nasal cartilage is a fixed point, is that right? And with the vertical growth, the top teeth drop down, so that line is going to be greater with the vertical growth.
I think
okay.
I have to take slight issue with the suggestion that the nose is a fixed point. The nose is a relative fixed point.
What do you mean by relative?
Well, as the top jaw drops back and down, there comes a point where it will pull the nose with it as well. And at that point, the nasal cartilage buckles, and you get a deviated nasal septum, which of course is very common in people who have severely crowded teeth, and I think is another symptom of craniofacial dystrophy. But also, of course, the greater body of the nose is cartilaginous. When you think of a skull, you'll notice that most of the nose is missing from the skull because it's cartilage. Well, the section just at the top is bony, and there's two little plates of the nasal bones that come up to about this point here. Now, if your maxilla goes back a lot, then of course you'll get a buckling at that point. And of course you'll get a famous hook in the nose, which is frequently removed by people wanting to make themselves look more beautiful. Now, this hook dates right the way back to the Roman era. Now, in the Roman era, your average proletariat, your average man in the street, or your slave, or your farm worker, or the vast majority of the population had almost perfect occlusion. But those exceptional privileged few, well, they could live on a modern diet, almost as calorie-rich as some of the diets we've got now. So they were some of, well, there were some people even before them, but they were some of the earliest groups to really be affected, and consequently we have this term of a hooked Roman nose. So I would think, had you gone back to the Roman era, you would see the privileged few with a longer indicator line, with the vast majority with some almost ideal indicator line.
It's interesting how we see these problems of civilization across history with that diet. So back to what you were talking about a little bit earlier. You were talking about somebody fixing their nose, with the nose dropping down.